Our first speaker this morning is Dr. Kendra Anderson, and she is an assistant professor with UT Health Neurosciences in the Department of Neurology at McGovern Medical School. She's a clinical neuropsychologist with interests in assessment and differential diagnosis of neurocognitive disorders, including dementia, stroke, multiple sclerosis, movement disorders, and behavioral intervention with adults and older adults with comorbid cognitive and psychiatric disorders. That's a big mouthful, right? She does a lot of stuff. She serves as a consultant neuropsychologist in an interdisciplinary clinic for individuals diagnosed with Huntington's disease, where she provides neuropsychological assessments and mental health assessments for predictive genetic testing. Dr. Anderson earned her doctoral degree in clinical psychology from the University of Central Arkansas in Conway, Arkansas, and completed her pre-doctoral internship at the UT Health Doctoral Psychology Internship Program in Houston, Texas. She completed a 2-year APPCN accredited postdoctoral fellowship in clinical neuropsychology at UT Health Neurosciences Neurocognitive Disorder Center. Her research interests include issues involving multicultural neuropsychology, access and health disparities in brain health, Huntington's disease, and non-pharmacological interventions for neuropsychological symptoms among adults with neurocognitive disorders. In addition to her clinical and research interests, Dr. Anderson is passionate about mentorship and service. She is the founding member of the Society for Black Neuropsychology and serves in multiple organizations and committees, including the National Academy of Neuropsychology, Culture and Diversity Committee, the International Society of Neuropsychology Committee, and the Houston Neuropsychological Society. She's a very accomplished professional, and we are exceptionally delighted she's joined our team. Dr. Anderson.
Wow, thank you for that magnificent introduction. You made me sound so much more impressive than Thank you so much. So I'm going to try to share my screen now and make sure you all can see my presentation. All right. Let's see here. Now, can you all see my presentation or my notes?
Yeah, tell them. Yeah,
yeah, you've got it. You're good.
Okay, so you see my full presentation? Wonderful, wonderful. All right, so I'm going to be discussing the cognitive changes associated with Huntington's disease. And today's presentation is meant to be kind of the cliff notes about some of the changes we can see in our loved ones who are living with HD. I'll give you a few tips. It's both patients and caregivers who are managing kind of these cognitive changes that happen. And we'll just generally go over the overview of why neuropsychological assessment may be beneficial in Huntington's disease care, and some of the treatments that are available. Okay, so here's kind of that basic outline of what we'll be discussing today. And I'll do my best to leave a few minutes for questions. Okay, so you'll probably hear this a few times throughout our presentations today, but Huntington's disease is an inherited degenerative brain disease due to an expansion of CAG repeats on the HTT gene, right? So when we think about Huntington's disease, we usually think about it as not only a movement disorder, but kind of this triad of symptoms and symptomatology. Usually the big thing that people think about when they think about Huntington's disease are these involuntary movements or chorea. But we know there are very early changes in cognition that can happen in Huntington's disease, as well as neuropsychiatric changes or these mood-related changes that can happen in Huntington's disease too. So for the purpose of my presentation, I'm going to primarily focus on the cognitive changes and talk about where Huntington's disease impacts the brain most. All right. So a little bit of brain anatomy 101. So here is kind of a picture of our brain. There's a few things missing here, just for simplicity's sake. But when we think about the brain, there are 4 major lobes. So our frontal lobes are very involved in voluntary movement, right? So our ability to inhibit movement and execute movement on a voluntary basis. But it's also extremely important in a number of cognitive functions. So for example, things like complex attention, being able to sustain your attention over time, being able to move your attention and direct it to where it needs to go, to monitor things in your environment. It's critical in planning, organizing, problem solving, making good making good decisions and having good judgment. It can be critical in language expression, so being able to express what you want to say to other people. And then, as we'll see here in a bit, it's very important in mood and social behavior. So our frontal lobes, it can really, if there's damage to the frontal lobes or if the frontal lobes are compromised, it can drastically change how we interact with our world and how we're able to, problem solve and think about conflicts and things that may arise in our environment. Then we have the temporal lobe, which it has a variety of functions, but for the most part, most people associate the temporal lobe with memory when it comes to cognition. But, it's involved in processing auditory information, so things that we hear. It's super important. It has a number of structures in the temporal lobe that are very important for learning and encoding new memories, right? So when things happen, how we take that information in, make sense of that information, and how we're able to remember it. It's very important in language comprehension. So while the frontal lobe is expressing what we want to say, temporal lobe is understanding what's being said to us. And then it also has some implications in like affect, emotions, emotional regulation, and things of that nature. We have a parietal lobe, which it's mostly involved in sensory perception and integration. So kind of knowing where our limbs are in space, very important in visual spatial perception. It's also important in what we can commonly see in Huntington's disease, something called insight, right? So our ability to be aware of our deficits and be aware of some of the changes that are going on. It's critical in praxis or our knowledge about how to do motor activities. And then it's also very important in reading and writing. And then let's see here. Finally, we have the occipital lobe. We won't focus much on this in my talk, but it's our primary visual cortex. It's involved in visual processing, judging distances and depth perception, color determination, and things like that. Okay. So when we think about the caudate, when we think about Huntington's disease, what we know through research is that Huntington's, the disease, it has a preference for impacting brain cells that are in a structure deep within inside the brain called the caudate, or the caudate nucleus. And the caudate nucleus is a C-shaped, if you can see here, it's kind of this, oops, go back. It's a C-shaped structure that lies deep inside the brain. And it's a part of a network of structures that's called the basal ganglia. That's important in a variety of cognitive functions, but we mostly think about it as being involved in movement. And so the caudate, it's usually divided in these 3 parts. We have the head of the caudate, which again, because of where it's located, it has these projections to the frontal lobe. And so we've talked about how important the frontal lobe is in, managing emotions and thinking and judgment and planning. And so the head of the caudate, because of its connection with the frontal lobe, can be very important in that executive functions we talked about, voluntary movement, reward, motivation, and understanding how to use feedback in the environment to adjust your behavior. So some anecdote, I love to give anecdotal examples of what this might look like in HD. So some families or patients that I work with, they may say, I just have a hard time getting motivated to do anything. I'm even independent of depression. We know depression can be important in Huntington's disease, an important mood change in Huntington's disease. But sometimes we'll see apathy independent of depression. And it's because of, these structures in the brain that are changing. In feedback, some people will say, I tell them over and over again, and it doesn't seem to stick, or they keep making the same mistakes over and over again, and it never seems to stick. Well, it's really important. These structures are important to being able to use that feedback in your environment and integrate it to change your behavior, and that can be compromised in HD. Mood regulation, social perception. We'll talk about these a little bit more in detail here in just a second. And we have the body of the caudate, which can be really important in learning, and also romantic feelings. So for example, I'll hear some spouses or loved ones, even very early on in the disease progression, they'll say, they just seem kind of disconnected. They don't really seem to have much empathy, or we kind of feel like roommates. I don't feel that romantic connection anymore. And again, it can be directly linked back to some of the changes that are happening in the brain. It's really important in goal-directed behavior and flexible behavior as well. And then finally, the tail of the caudate. It's also important in learning acquisition, but also visual discrimination, being able to tell different visual things in the environment, discriminating between those things, visual information processing. The tail of the caudate, it has these projections to the temporal lobe, and that's why we can see some changes. They're usually not prominent in HD, but we can see some changes in things like visual memory and just kind of visual spatial changes that can be related and important for driving safety. All right. So when we think about the overall neuropsychological features of Huntington's disease, or the most prominent features in Huntington's disease, one of the earliest changes that we see is something called psychomotor slowing. So this is just a general slowing of motor speed and a general slowing of thinking processes. And this is the earliest change that can happen in the disease progression. There's some literature that shows that changes in processing speed can happen as early as 10 to 15 years before the onset of motor symptoms, right? So these cognitive changes are happening maybe even well before someone knows they have a Huntington's disease, if they haven't, undergone the predictive genetic testing process. Executive functioning, which we've talked about quite a bit here. People, they will show these deficits in attention, being able to plan. You may say, well, they used to be able to plan their doctor's appointments just fine, or plan a trip just fine, but now they have a lot of trouble with that. Keeping things organized, sequencing, right? So how this shows up is they may be able to tell what happened, but it's kind of out of order. They can't really put it together in a sequenced way that makes sense. And then just verbal fluency, getting out the words in a fluent way. Memory, I think, is one of the things that people, I think, identify the most is, I'm having trouble with remembering things. Usually, though, it's because of the problems in executive functioning. For example, when asked to recall things in HD, individuals living with HD, they may have some trouble recalling it just free recall, but usually if they have reminders and cues, it really helps. What we usually see is something that we call this frontal pattern, in the sense that because of their issues in executive functioning and the changes in the frontal lobe, like maybe they aren't able to pay attention as well or sequence as well, that free recall without any reminders is difficult. But if we give them a little bit more time and we give them more cues, it can be very helpful. And sometimes there can be this problem with source memory, meaning that they might remember it, but they might misremember where they heard it or who said it, and things of that nature. And then social cognition. Again, social cognition can be a very early change in the disease process. And these are typically associated with problems with processing facial and vocal expressions of emotion, particularly negative emotions. So things like disgust, anger. So some families, they'll say, well, you could hear I was upset in my voice, but it seemed to not really register with them. And so it can really complicate close relationships early in the disease before people really know that, that HD may be having an impact. Okay, so I wanted to spend a little time just talking about what I do and what a neuropsychologist is. And so a neuropsychologist is a clinical psychologist who specializes in understanding the relationship between brain and behavior relationships. And so kind of just how I demonstrated there, these changes that are happening with structures in the brain can be directly associated with changes in our behavior. And neuropsychologists have a unique kind of expertise in that, so we can explain it to individuals living with HD and their families. And so clinical psychologists or clinical neuropsychologists can be extremely helpful for patients and families living with HD to be able to discuss the well-being, emotional well-being prior to undergoing predictive genetic testing. We can help families and individuals living with HD understand how the disease impacts mood, memory, and daily functioning. And then we work closely with the neurologists and other healthcare professionals that might be involved or that might work in an integrated care setting, like psychiatrists or genetic counselors, social workers, to be able to give a broad overview of their patients' like cognitive strengths and weaknesses, as well as their functional abilities. Because what we may see is that everyone's journey with HD is very different. Some have a more cognitive onset, much earlier than the movements may start. Some people, it's relatively mild or later onset and it's more kind of movement based. And so we want to get a good overview of how someone's functioning so we can best tailor treatments and recommendations to their needs. Okay, so what's involved in a neuropsychological evaluation? So a neuropsychological evaluation is assessment of how an individual brain functions. So when you go in and you go in to see someone like me, you will likely spend about 2 or 3 hours, talking about your concerns, talking about the changes that you witnessed in yourself or in your loved one. And then you'll be administered a battery of tests that assesses all those functions that we talked about earlier, like processing speed, executive functioning, memory, language skills. And then those scores, we score those tests up, and your scores are interpreted and compared to scores of what we call your peer group. So other individuals your same age and level of education. And there's been, I think, much research and efforts made to be able to get a normative sample that's included of patients living or individuals living with Huntington's disease, so we can have a better group to compare people who present for neuropsychological evaluation who are at risk of HD or who are genetically confirmed. And then neuropsychological evaluation, it evaluates, again, those multiple areas that we've discussed, including mood and quality of life. Many assessments or report forms that I give to also assess caregiver stress. All of those things are extremely important, and all of those are important to consider when working with individuals and families living with HD. So you may ask, man, 2 to 3 hours doing tests? No, thank you. Why is it even important to get a neuropsychological evaluation, and why is it important in Huntington's disease care? So it can be really helpful to assist with differential diagnosis. If for individuals who may have already undergone the predictive genetic testing, this may not be as big of a benefit, but it can be for individuals because there can be different reasons for chorea, right? So we can really help with the differential diagnosis. We can assist with evaluation of the efficacy of treatments. So for example, if they're giving different medications and trying to tailor them to your needs, we can assess and see, well, are these treatments actually doing what they say they're doing? Is this medication helping with their cognition? Is this medication helping with their mood? One of the most common reasons, at least in the context of an interdisciplinary clinic in which I work, is to provide a baseline against which subsequent evaluations can be compared. As I said earlier, cognitive changes are actually the first changes, the earliest changes that happen in HD, often years before the movement symptoms are notable. So this can be really helpful and particularly important in disability claims and when you're going up for Social Security disability, because especially for those individuals who are experiencing cognitive changes are directly associated and are the best predictor of functional status, right? So those changes in executive functioning, they are directly implicated in people's ability to work. And so what we may find sometimes is that even among individuals who may not have motor symptoms yet, they can have these cognitive changes that can interfere with their ability to work efficiently and effectively. So this can be imperative for some people because we can get a baseline at the very first onset or after they're genetically confirmed, and then we can have subsequent neuropsych evaluations that can monitor and track progression over time to give updates about their current cognitive functioning, and it's an objective measure that will show that there is decline if there is any. And then it can reveal areas of daily functioning to identify areas that the individual may need assistance or rehabilitation. The overall goal is to keep the patient as independent as possible. And so neuropsychological evaluation can be extremely helpful in knowing what areas they may need more assistance in and what areas maybe they can still do independently. So some tips for managing cognitive changes include encourage one thing at a time. Because of those changes in the frontal lobe, doing multiple things and multitasking, taking on multiple tasks will be extremely difficult as the disease progresses. Separate tasks into manageable components, provide structure and external memory aids instead of relying solely on just being able to remember without any notes or visual cues. And then using external stimulation to improve motivation. Apathy, it can be a very debilitating neuropsychiatric change that can happen in HD that can decrease engagement and can really complicate, social engagement. So anything that you can do to keep, your loved one with HD or yourself active, it is going to be critical. Okay, and then in terms of treatments for HD, currently there are no disease-modifying therapies for HD, but there are some assistive technologies that can be used. For example, external aids to help compensate for cognitive difficulties. There's been some literature to show that talking mats for individuals who have speech difficulties as HD progresses can be really helpful in helping them communicate their needs and lowering some of the frustration that can happen due to speech changes that can happen in HD. Medications, your neurologist may prescribe you something to help kind of slow the cognitive decline early on. There is some literature that shows that some use what's called acetylcholinesterase inhibitors, which are used to kind of improve memory. But the evidence is a bit limited for use in HD. And then cognitive training early on in the disease process, or if you're what we call pre-manifest, so in the stage of Huntington's disease where you're not showing any, motor symptoms. Cognitive training can be, there's some literature that shows that cognitive training interventions can support neurocompensation, meaning that, physical exercise and cognitive training can slow the progression of the cognitive changes that are happening. So I just wanted to do a quick shout out to our HGSA Center of Excellence team. We have our fearless leader, Dr. Erin First-Stemming, who's wonderful and who you'll hear from shortly. And then just a wonderful network of professionals that are really passionate about HD care. So I'm extremely privileged, and I feel it's an honor to work alongside Dr. First-Stemming in the UT Health HGSA COE team. So that's my presentation. I feel that I wanted to be sure to leave a bit of time for questions or comments. And here's my email address if you'd like to reach out for questions or concerns. So thank you for your time and attention.
I hope you can, I wish you could hear me clapping, Dr. Anderson. Thank you so much for such a thoughtful and relevant topic for our community.